Good morning, everyone. My name is Donna Kelly-Williams, and I am the president of the Massachusetts Nurses Association, National Nurses United, which represents more than 23,000 registered nurses and healthcare professionals in the Commonwealth, which includes the ICU nurses in more than 70% of the state's acute care hospitals. First, we thank the Health Policy Commission for holding this critically important Patient Safety Initiative listening session for nurses and other stakeholders. We have great expectations of the Health Policy Commission, having worked with you in the development of the definition of emergency and other issues related to the recently passed law on the ban on mandatory overtime. In drafting this new law on safe patient limits in the ICU, we were insistent that your expertise and leadership would be pivotal in the development of regulations regarding the implementation and compliance with this law, which is why we are here today. In preparing for this listening session, we have actively engaged with our membership throughout the Commonwealth, meeting with and surveying thousands of nurses from inside and outside the ICU for their input on the acuity criteria needed to ensure appropriate care and monitoring of ICU patients. Karen Higgins, co-president of National Nurses United, and herself a practicing ICU nurse at Boston Medical Center for more than 30 years, will present our official testimony outlining the specific acuity criteria that we believe must be included in an effective acuity tool. In addition to Karen, there are nurses here today from ICUs around the state to share their views on the acuity criteria which is needed to safely care for their patients. Also with me on this panel is Professor Judith Shindul-Rothschild of Boston College, who is here today to present testimony on the specific quality indicators that we believe should be measured in connection with this law. And beside Judy is the MNA NNU Executive Director, Julie Pinkham, who will provide our recommendations for regulations governing compliance with this law. Our organization was the driving force behind the creation of this law, and Julie Pinkham and I both participated in all discussions and negotiations surrounding the drafting of this law, which was approved and endorsed by the Massachusetts Hospital Association. The language of the law was carefully crafted, and every word in the law, as well as words that were specifically not included in the law, are important as it reflects the intent of the legislation in providing this patient safety protection. In my testimony this morning, I wanted to take a few minutes to clarify exactly what the law means, as we have since learned that many hospital administrators and managers clearly have misinterpreted the law, which has led to a failure of some hospitals to follow the law, thus endangering the patients under their care. Underpinning all of these discussions is the clear fact that the law establishes a one-to-one nurse-to-patient assignment as the baseline standard of all patients in our hospital ICUs. The rule of this law is that an ICU patient should be singled with a nurse and can only be part of a two-patient assignment if and when the assessment of the nurses on the unit and the acuity tool determines that the patients are stable enough to be doubled. We were careful in crafting this law to ensure that the decision to double a patient was based on the needs of the patient as outlined by the criteria established for using an acuity tool and based on the judgment of the staff nurses providing that care. The law is very clear that managers and administrators have a very limited and specific role in determining if and when a nurse can take a second patient assignment. And that role comes into play only in those instances where the staff nurses on the unit cannot agree on the proper patient assignments. At that point, the nurse managers help to resolve the dispute. It is not the role of the manager to overturn the assessment of the staff nurses. We also feel that it's important to point out that the law is now in effect and has been since September 28th. We say this as some hospitals have been telling ICU nurses that they do not need to follow the law until the acuity tool is finalized. In conversations with your executive director, we have clarified that the law is indeed in effect. Hospitals now must be meeting the one-to-one standard, and until the acuity tool is developed, it is our contention that the staff nurses on the unit, as stipulated in the law, will make the assessment of when a patient is stable enough to allow the assignment of a second patient. As stated earlier, if there is any disagreement, a manager or designee will then be involved to resolve the dispute. We also want to take a moment to state what is purposefully not mentioned in the law. The law does not allow for a one-to-one patient assignment to suddenly become a one-to-two patient assignment because the nurse will be on a legal meal break. Nor does the law provide exceptions for a nurse with a one-patient assignment to take a second, third, or fourth patient because a nurse on the unit has to travel with one of her patients to an MRI or another procedure. The law also does not provide exceptions for financial concerns. A hospital whose surplus, profit, or margins are less favorable than their competitor is not allowed to avoid compliance with the law. That is a matter to resolve in a different forum. The law is for the patients, specifically to create a safe standard without exception. We are here today to assist you in doing the important work of ensuring nurses who care for these critically ill patients are working with acuity criteria that supports the staff nurse's assessment of what constitutes a safe patient assignment. We are also here to help you determine what rules and procedures need to be in place to ensure hospitals are complying with this law to ensure patient safety. And finally, we are here today to help you in identifying appropriate quality indicators to measure to be determined the success of this law in protecting our patients. Thank you very much.
Okay, so we have like 3 minutes. And again, but I'm just saying we don't need to be, please, we do not need to be reminded about what the law is. I do appreciate, though, you clarifying that it is in effect on September 28th. We do agree, of course, but of like really what the regulations should look like and what we should safeguard. That would be really helpful. Okay. I do, of course, appreciate your comment.
I'm Karen Higgins, and I am an ICU nurse at Boston Medical Center, but I'm here hopefully to provide comprehensive recommendations for appropriate acuity criteria that we believe should be included in the acuity tool and that all hospitals should be adopting for ICU nurses. And I believe they've given you a copy, so I am not going through the whole thing. I'm just going to hit some of the highlights of what we have concerns about. Just to give you a quick update, we actually met with several hundred ICU nurses who worked in all manners of ICUs across the state of Massachusetts, from the largest tertiary groups to the smallest community hospitals in every state. And we asked them to tell us for their units and their patients what clinical factors or level of patient status would dictate a one-to-one assignment. And so we got all the information, we went back, we reviewed it again, went back to the ICU nurses a second time to make sure that we were right. There were 3 sets of recommendations that the criteria that was developed in the types of ICU. So there was the medical ICU, surgical ICU, coronary care unit, burn trauma unit, and then there was a separate set of protocols set up for pediatric ICUs and neonatal ICUs. And as you can see, if you lead through the top of this criteria, there's a especially in the MICU, medical ICU and the SICU, there's various clinical criteria that is further categorized under specific headings, such as issues related to patients with respiratory issues, cardiac issues, surgical, neurological, and so on. As you look at the first set, there's about 43 specific situations that we feel strongly patients would be considered to be one-to-one. If they're opposed to cardiac arrest or respiratory arrest, a ventilator dependent or intubated patient requiring frequent interventions for respiratory compliance, suctioning, trach care, sedation protocols. Patients in septic or cardiogenic shock requiring continuous monitoring and needing multiple intravenous vasopressors and hemodynamically unstable. Patients in acute organ failure, which is liver, kidney, brain, require constant monitoring and intervention. And we have a similar list if you look at it for the pediatric and neonatal patients as well. And all of these lists, it's our recommendations would demand that these situations would demand a one-to-one assignment without exception. Further on in our recommendations, as we looked at the acuity too, we asked look at the when the patient comes into the ICU is admitted, and then it's verified about every 4 hours at least in how this patient is doing, and that it gives the nurse the ability that if the changes in the patient require that the patient then become one-to-one, that there is a system where she can actually bring that up and have that happen so that in fact the patient will continue to get the care that they deserve and not be left hanging because there isn't somebody else there to help them out. So we know that. We believe of all the criteria and we believe all of this criteria and potentially more should be included when you look at the acuity system. And we want to avoid any confusion and leave no door open that gives the opportunity for it to be circumvented or not followed through with. I think the law has been very clear on what we need to have in place and that ensure that this is a tool, as we all said, and that it's still up to the nurse to make that decision. As we look further on in the list of, we needed to look at the environmental factors, and we believe these are essential when we look at an acuity system. Again, if you look at the top of the two pages of each set of criteria, you'll see essential environmental factors that we think also play a role. A clinical assignment for a regularly scheduled nurse on a particular ICU may be significantly different on a unit than it would be staffed with temporary nurses, per diem nurses, or travel nurses. We need to look at the availability and the nature of the support staff, which also impacts the ability of that nurse to be able to take care of more than one patient or just one patient. And that's the question of whether is there a hospitalist in the unit, is there a physician assistant in the unit, is there a secretary in that unit, the appropriate number of aides to be able to assist with the patient's care. We want to look at the physical layout of the unit. It must be considered. Is the patient in one room? Are there more than one patient in a room? We want to look at, is it visibly easy to see this patient? Is it easy to see the monitoring of this patient? We need to look at that. We need to look at the equipment that's available that helps in taking care of patients, whether it's the type of bed we're using, whether it's lifting equipment. This all affects everything that we do. Now coming into play in the last couple of years has now been wonderfully well of our documentation system and our medication administration, which has been changing drastically for us in the last couple of years. And these are hugely playing a factor in time, in the use of our time, and being able to take care of more than one critically ill patient. So we need to look at that very, very carefully. We also believe there should be a means of calculating the time required now to actually admit and discharge a patient, as well as the amount of time it takes when the staff has to transport a patient, when we respond to codes, which most of us do. And we are now also becoming part of what they call a rapid response team, which is when there's an event out on the floors. And in some cases, even if it's not a patient that unfortunately has an event within the hospital when they're visiting, a lot of places it's the ER nurses that are responding, and sometimes what we try to do is assist them with that. So these all actually take away and continue to play a role in what we do, trying to take care of critically ill patients. We believe the acuity system must include both these factors. Now, the only thing that I really wanted to also bring up, because it came up in the discussion when we were talking to the ICU nurses, is that when patients are discharged from ICUs, we're finding that there's been a lot of concern from nurses that they feel the patients are being, quote, dumped out of ICUs and onto either a step down or a floor, not because the patient was really ready to go, but because they felt that they needed that bed for another patient. And we find this is becoming a huge issue, and we want to be really clear that if that patient still meets that criteria, that acuity criteria, that they should not be moved out, or if they're going to be moved out, that we provide the same level of care that they would require in the unit, outside that unit. We have similar concerns about the ER.
So again, I don't,
Oh, I'm
trying
sorry.
to be,
Let me just finish this one, because I think you need to hear it, because what we're finding is that patients in the ER, it's the same issue. Patients are in the ER, they're sitting in the ER waiting for an ICU bed, and that ICU patient, that nurse has several other patients as well as that ICU patient to take care of. So we need that to be looked at as far as going forward. And I think that is pretty much, other than the 20,000 pages you have, of what we are highly
I appreciate
recommending. But I just want to hit the highlights. Thank you.
thank you. No, this is true, this is very helpful. No, but again, I'm just, no, thank you. So please do not read your testimony. Please, we just can't. It's out of fairness to, we're up to 15 minutes with one panel. We have 45, 50 people. So we will either need to schedule a second one, listening session, because we don't want to be disrespectful to folks. But if there's highlights, again, we do not need to be reminded what's in the law, but what we need to really attend to ensure that the regulations meet the intent and spirit and letter of the law. That would be very helpful. Please do not read your testimony to us.
Good morning.
Good afternoon.
Good afternoon. My name is Judith Shindul-Rothschild. I'm a registered nurse that has been employed in the Commonwealth for over 35 years. I am currently working as an associate professor at the William F. Connell School of Nursing at Boston College. I believe I am the only researcher in the Commonwealth of Massachusetts who has examined associations between registered nurse staffing and patient outcomes. Today, based on my research, and you have some copies of some of my recent publications and the research I'm presenting today, we're working on a publication with Dr. Sean Clark, who has published breakthrough research with Linda Aiken on failure to rescue for patients, which you'll see is one of the indicators here. So this hopefully will be out in print shortly. We conducted a longitudinal analysis using publicly available data from the Massachusetts Hospital Association. We calculated average nurse-to-patient ratios on intensive care units, step-down units, and medical surgical units for all Massachusetts hospitals from 2009 to 2013. Then we did a statistical analysis of over 20 indicators, patient safety indicators, healthcare acquired conditions from AHRQ, as well as the HCAP survey, which I know may come as a bit of a surprise to you, but those were some of the most robust findings we found actually from CMS. So the 5 nurse-sensitive outcomes we would recommend strong consideration. The first one that had very robust association with nurse staffing was patients' perception of how well their pain was controlled. And in the testimony you'll see I've indicated who collects this measure, the name of the measure, and in the appendix, and I refer you to the appendices where you can see our statistical analyses. I've tried to make it very clear where we've broken down the nurse staffing from the best nurse staffing, the lowest quartile of patients to nurses, to the middle 50%, to the top where they're quartile, where nurses are assigned the most patients. And you can see those linear relationships, just to make it easy for you to eyeball it. The second nurse-sensitive outcome would be postoperative wound dehisce. It was very robust. Studies show that proper surgical and nursing care prevent wound dehisce, and that was robust really across all 3 levels of care. The third is poor glycemic control. Again, the National Clearinghouse of Patient Outcomes states that through careful nursing surveillance, poor glycemic control can be controlled, and we found that there was a clear relationship. If you look also at the very last figures in each of these areas, we provide a scattergram with the hospital names. So we couldn't put them all there, right, because you wouldn't be able to read them. So some of the names have been suppressed, but it just gives you an idea of putting the name of a hospital to a data point so you understand what those relationships are and what hospitals are we talking about that are really the outliers here. The fourth is one well-known. AHRQ calls it death among surgical inpatients with serious treatable conditions, death per 1,000 discharges. We know it as failure to rescue. And our research again found significantly higher rates of preventable deaths occurring with higher rates of patients assigned to RNs and CCUs and ICUs. And I would just like to take one moment to follow up on a point that Karen Higgins made about the step-down units. You'll see if you go, and it's in appendices 15 to 17, that on the step-down units is actually a bell-shaped curve where the number of preventable deaths spikes in that middle 50%, the average nurse staffing. And I think that, I was talking about this with Dr. Clark yesterday before coming here, and we were brainstorming about this, and I said, I think that's because these are patients that should have been kept in an ICU that weren't, and so we're going to try to tease that out as we work in our publication to, when we flesh this out a little more. And the fifth one is falls. And as you know, that's one of the top sentinel events that has to be reported to the Joint Commission. We found a linear pattern in ICUs and CCUs. It's not statistically significant because actually in our state the number of falls it doesn't happen that often, but you do see that linear pattern. So let me just quickly summarize. The number one is pain control as reported by CMS and HCAPs. Number two is post-op wound dehisce. That's a PSI reported by AHRQ. Number three is poor glycemic control. That's a HAQ reported by, I hope I'm not talking gobbledygook, healthcare acquired condition reported by AHRQ. failure to rescue, patient safety indicator reported by AHRQ, and inpatient falls, healthcare acquired condition reported by CMS. The other two nurse-sensitive outcomes that I recommend to the committee for future consideration, they weren't as robust. I was asked to limit my recommendations to 5, but I think they should be put in the pot for consideration, would be central venous catheter-related bloodstream infections and pressure ulcers. And if you go into the appendix, you'll see some of the relationships there. They exist, but they just aren't as robust. So if I can be of any other service to the commission, you have my contact information, and you can have lunch at the faculty dining room.
Like I said, I can find you across the street.
Easy.
Yeah.
So I'm just going to submit the testimony, and my only points that I'll make is we obviously think there should be reporting. That would be number 1. Number 2, we fully support Judy's recommendations, Dr. Rothschild's recommendations on the indicators. As far as the reporting on the staffing compliance, our suggestion is that that reporting, which the testimony would be more robust, but in the minimum would be monthly, and then an annualized data as well, which should be placed on the website so that the public can understand it in an easily accessible and easily understood manner. Also, with regard to the quality indicators, that those should be done quarterly and then annually, also placed on the website in an easy to understand manner. And then lastly, with regard to compliance with this, obviously, everything that should be done, we believe, should be done in order to assure compliance. I would say that at a minimum, that the compliance with the law and any associated regulations, that at a minimum, access to any funding or grants awarded to the commission now or in the future should not occur if there is non-compliance with this law. All right, and then the last point that I would like to make, which is briefly made by Donna, is that it's equally important what's not in this law. There was painstaking measures on things that were not acceptable. While I fully appreciate the work of DPH's funding is not adequate to be able to handle the data, and we believe that the CHIA website and the CHIA data is the appropriate place to put this because that is where the data is being collected anyway. I'll leave it at that, okay?
Thank you, Donna. Thank you.
Thank you.
Thank you.
Thank you.